Most people believe that if a surgeon recommends an operation, it must be the right call. I used to believe that too, until I started counting. Counting the patients who went in for routine procedures and came out permanently changed. A 68-year-old retired teacher named Margaret, active grandmother, walked 3 miles every morning. Clean labs. Her doctor said a simple knee replacement would get her back to hiking with her grandkids. 6 months later, she was still on blood thinners for the clot that formed during recovery. She never hiked again. Here's what nobody told her before she signed that consent form. What I'm going to tell you today. My name is Dr. Michael Harrington. I'm a cardiothoracic surgeon with 28 years in the operating room. I've opened over 2,300 chests. I've held beating hearts in my hands. And I've spent nearly 3 decades watching the same preventable patterns repeat. Patients who did everything right and still ended up on my table because a well-intentioned procedure went sideways. The system rewards the prescription, not the follow-up. It rewards the operation, not the alternative. Today I'm going to tell you what nobody took the time to explain to them. 4 specific surgical procedures that carry significantly higher complication rates for people over 60. Not because surgeons are careless, because your body after 60 is fundamentally different. Stay with me. Before we get to the list, you need to understand why the body after 60 responds differently to surgical stress. Think of it like an old car. A 30-year-old body and a 70-year-old body can both handle a long drive. But the older car has less margin for error. The radiator runs hotter. The shocks absorb less. One unexpected pothole that a newer car would barely notice can cause real damage. Your body's reserve capacity, the backup systems that carry you through physical stress, drops below critical thresholds after 60. Inflammation takes longer to resolve. Blood clots form more easily. Anesthesia clears more slowly. Muscles lose mass faster during immobility. More than 50% of adults over 65 experience what we call frailty creep, a slow decline in physiological reserve that doesn't show up on standard pre-op tests, but dramatically increases surgical risk. That margin for error I mentioned, it gets smaller every year, and smaller margins mean bigger consequences. Now, the first procedure on this list surprises people every time, because on paper, it looks routine. Number 1, elective spinal fusion for chronic back pain. The promise is simple. Fuse the unstable vertebrae, eliminate the pain. But here's what happens inside the body. Spinal fusion requires hours under general anesthesia, significant blood loss, and extended immobility during recovery. For someone over 60, that combination is a perfect storm. The longer you're under anesthesia, the higher your risk of post-operative cognitive dysfunction, what families often describe as not quite the same after surgery. Studies show that up to 40% of seniors experience measurable cognitive decline after prolonged anesthesia, and for some, it never fully resolves. Then there's the immobility. When you're lying in bed for days or weeks after spinal surgery, your blood becomes more prone to clotting. Deep vein thrombosis risk triples in patients over 65 compared to younger adults undergoing the same procedure. I've seen patients go in for back pain and come out with pulmonary embolism. Let me tell you about Harold, 71 years old, chronic lower back pain for 5 years. His surgeon recommended fusion. Harold asked me what I thought. I asked him one question. Can you still walk? He could. 2 miles a day, slowly, with a cane. I told him what I'm telling you now. If you can still move, if you can still function, the risks of spinal fusion after 70 often outweigh the benefits. Conservative management, physical therapy, pain management, anti-inflammatory protocols doesn't have the same definitive appeal as surgery, but it also doesn't carry the same risk of life-altering complications. Harold chose to wait. 3 years later, he's still walking. Still in some pain, yes, but he's walking. And he's cognitively sharp. The other factor most people don't consider is this. Spinal fusion changes the biomechanics of your entire spine. When you fuse 2 or 3 vertebrae together, you eliminate motion at that segment. That sounds like the goal. Stop the painful movement. But your spine needs to move. When you eliminate motion at one level, the vertebrae above and below have to compensate. They move more than they were designed to. Over time, that accelerated wear leads to what we call adjacent segment disease. The levels next to your fusion start to degenerate faster. Within 5 to 10 years, many patients need another surgery, and another. It's called the fusion cascade. You start with 1 level, end with 4. Each surgery carries the same risks we just discussed: anesthesia, immobility, cognitive impact. And each surgery is harder than the last because you're operating through scar tissue. Here's the question to ask your surgeon if they recommend spinal fusion after 60. Write this down. What is my frailty score, and how does that change my complication risks? Most surgeons won't have calculated it, but the fact that you asked changes the conversation. It forces them to think beyond the technical success of the procedure and consider whether your body can actually recover from it. The fix here is not to avoid surgery at all costs. It's to exhaust every non-surgical option first. Physical therapy, weight loss if needed, nerve blocks, epidural steroid injections, anti-inflammatory diet modifications. Give it 6 months of genuine effort. If you're still debilitated, then surgery becomes a different calculation. But starting tonight, if you have chronic back pain and a surgeon has mentioned fusion, ask that question. And don't sign anything until you get an honest answer. Number 2, and this one is harder to talk about because it involves the heart. Elective valve replacement in patients over 75 with moderate valve disease. I'm a cardiac surgeon. I perform these operations. But I also know when they're being offered too aggressively. Here's the mechanism. When a heart valve starts to fail, it doesn't always need immediate replacement. Moderate aortic stenosis, or mitral regurgitation, can be managed medically for years in many patients, especially if symptoms are mild or controlled with medication. But the existence of the abnormality creates pressure to fix it. And once you're in the system, once the cardiologist says, we should keep an eye on this, the conveyor belt towards surgery starts moving. The problem for seniors is this. Open heart valve replacement is one of the most physiologically demanding operations a human body can endure. You're placed on a heart-lung bypass machine. Your heart is stopped. Your blood is oxygenated artificially. Your body temperature is lowered. For a 45-year-old, recovery is hard, but predictable. For a 78-year-old, it's a different story. Stroke risk during bypass is 3 times higher in patients over 75. Kidney injury from the bypass pump is significantly more common. Post-operative atrial fibrillation, an irregular heartbeat that often becomes permanent, occurs in nearly 50% of elderly patients after valve surgery. That's 1 in 2. And if you develop permanent atrial fibrillation, you're now on blood thinners for life, with all the bleeding risks and dietary restrictions that come with them. 2 more items after this one. And number 4, that's the one that even I had a significant blind spot about for the first 15 years of my career. Stay with me. Let me ask you something. Do you know whether your current quality of life with moderate valve disease is actually worse than your likely quality of life after major valve surgery at your age? Most patients don't, because the conversation focuses on the valve, not on the whole person. I've had patients in their late 70s come to me with moderate aortic stenosis, still gardening, still driving, still living independently. And I've had to ask them, honestly, whether the 20% to 30% chance of a major complication, stroke, cognitive decline, permanent arrhythmia, dialysis, is worth the possibility of slightly better exercise tolerance. Sometimes the answer is yes. But often, once they understand the real numbers, they choose to live with the valve they have. The question to ask your cardiologist: if I do nothing and manage this medically, what is my realistic prognosis over the next 5 years? And then ask, what percentage of patients my age have a major complication from this surgery? Don't let them give you the overall complication rate for all ages. You need the rate for your age group. If they say it's low, ask them to define low. Is it 5%, 15%, 30%? Because those are very different risks, and you deserve to know which one applies to you. The fix here is not to refuse all valve surgery. It's to refuse premature valve surgery. If you're symptomatic, if you can't walk across a room without getting short of breath, if you're having chest pain, if you're passing out, then surgery is likely the right call. But if you're living your life and the only reason surgery is being discussed is because an echocardiogram showed moderate disease, you have time. Use it to get a second opinion, preferably from a cardiologist who doesn't perform surgery. Number 3, gallbladder removal in patients over 65 with asymptomatic gallstones. This one frustrates me because it's so common and so unnecessary in many cases. Here's the setup. You go in for an ultrasound for something unrelated. They find gallstones. You have no symptoms, no pain, no nausea, nothing. But the radiologist puts it in the report. And now your doctor says, we found stones. We should probably take it out before it becomes a problem. That logic sounds reasonable, but it's based on a faulty assumption. The assumption is that gallstones always eventually cause problems. They don't. Studies show that up to 80% of people with gallstones never develop symptoms, ever. They live their entire lives with stones in their gallbladder and never know it. But once you know they're there, the psychological pressure to remove them is enormous. Here's what happens during gallbladder surgery in seniors. Laparoscopic cholecystectomy, that's the technical name, requires general anesthesia and insufflation of the abdomen with carbon dioxide to create space for the instruments. That insufflation increases pressure inside your abdomen, which decreases blood flow to your intestines and can cause temporary kidney impairment. For younger patients, this resolves quickly. For seniors, especially those with any baseline kidney dysfunction, it can tip them into acute kidney injury. I've seen patients go in for a gallbladder removal and come out needing dialysis. Not often, but it happens. And when it happens to someone who had zero symptoms before surgery, it's a preventable tragedy. Then there's bile duct injury. The common bile duct runs right next to the gallbladder. During removal, there's a small but real risk of accidentally cutting or clipping it. In experienced hands, that risk is about 1 in 300. But in patients over 65, the anatomy is often more difficult due to scarring, inflammation, or previous abdominal surgery. The risk doubles. A bile duct injury is a catastrophic complication. It requires emergency revision surgery, often an open procedure, and can lead to lifelong digestive problems, infections, and chronic pain. All because you removed an organ that wasn't causing any trouble. Here's what nobody tells you. If your gallstones are asymptomatic, the lifetime risk of developing symptoms is only about 20%. That means an 80% chance you'll never have a problem. Compare that to the risk of surgery. Anesthesia complications, bile duct injury, infection, post-operative pain, and the fact that some people develop chronic digestive issues even after uncomplicated gallbladder removal. The math doesn't add up. The fix here is simple. If you have no symptoms, do nothing. Monitor. If you start having pain after eating fatty meals, nausea, or right upper abdominal discomfort, then you revisit the conversation. But removing a gallbladder just because stones showed up on an imaging study? That's not evidence-based medicine for asymptomatic seniors. That's defensive medicine. And you don't have to participate in it. Number 4, and this is the one I missed for years. Prophylactic mesh repair for small, asymptomatic hernias in patients over 70. I was trained in an era when the standard teaching was, if there's a hernia, fix it before it becomes incarcerated. Incarceration is when a loop of intestine gets stuck in the hernia sac and loses its blood supply. It's a surgical emergency. So we were taught to repair every hernia we found, even small ones, even if they cause no symptoms, to prevent that emergency. But the data that's come out in the last decade has completely changed that thinking. And a lot of surgeons haven't updated their approach. Here's the problem. Hernia repair, especially with mesh, has a complication rate that many patients don't understand. Mesh is a foreign material. Your body has to incorporate it. In some people, it does so without issue. In others, the body rejects it, leading to chronic pain, infection, or mesh migration. Studies show that up to 15% of patients experience chronic postoperative pain after mesh hernia repair. That's not short-term surgical pain. That's pain that lasts months or years. For some, it's debilitating. And in seniors, the risk is higher because tissue quality is poor, healing is slower, and the mesh is more likely to erode or migrate. I've seen patients who had a small, painless inguinal hernia go in for elective repair and come out with nerve damage, chronic groin pain, and an inability to walk comfortably. The hernia wasn't bothering them. The surgery destroyed their quality of life. Let me tell you about Robert, 72 years old. Noticed a small bulge in his groin during a physical exam. No pain, no discomfort. Could still play golf 3 times a week. His surgeon recommended mesh repair. Robert asked me. I told him what the data shows. For small, asymptomatic inguinal hernias in men over 70, the risk of incarceration requiring emergency surgery is less than 2% over a 10-year period. The risk of chronic pain after elective mesh repair is 10% to 15%. Robert chose to wait. 5 years later, the hernia is still there. Still small. Still causing no symptoms. He's still playing golf. He made the right call. The question to ask your surgeon if they recommend hernia repair. What is the actual risk that this hernia will become incarcerated if I do nothing? Make them give you a number. Not a vague, it could happen. A percentage. And then ask, what is the risk of chronic pain or mesh complications after surgery? If the risk of doing nothing is lower than the risk of surgical complications, the answer is obvious. The fix here is watchful waiting. If the hernia is small and asymptomatic, you monitor it. You check it every few months. If it starts growing, if it starts causing pain, if it starts showing signs of obstruction, then you act. But prophylactic surgery for a hernia that's minding its own business? Not after 70, not unless the numbers strongly justify it. I want to be honest with you for a moment, not as a content creator, as a surgeon. I have stood at an operating table at 3 in the morning, holding a heart that had just survived 6 hours of surgery, but would never beat quite the same again. I have spoken to families in waiting rooms at dawn, families who had no idea anything was wrong when they said goodnight 8 hours earlier. In case after case, the contributing factors were not mysterious. They were elective procedures offered too aggressively. Small problems turned into large ones by well-meaning interventions. These are not exotic risks. They are the background noise of millions of ordinary consultations in millions of ordinary exam rooms. And that background noise, accumulated year after year, procedure after procedure, creates outcomes that nobody wanted and everyone regrets. I want to tell you about a patient. I'll call her Linda. 69 years old, retired school librarian, sharp, independent, fiercely protective of her autonomy. She came to me after a routine physical revealed moderate mitral valve regurgitation. Her cardiologist recommended surgery within the year. Linda asked for a second opinion. We ran a full workup. Yes, the valve was leaking, but she had no symptoms. Her ejection fraction was normal. Her exercise tolerance was fine. We put her on medical management, a beta blocker, an ACE inhibitor, close monitoring every 6 months. 4 years later, her valve hasn't worsened. She's still independent, still driving, still volunteering at the library twice a week. The first thing she said to me at her last visit was, "Why didn't anyone tell me I could wait? Why was surgery the first thing they talked about?" That question stays with me. It's a big part of why I make videos like this one. It is never too late to ask better questions, to demand better answers, to take back control of decisions about your own body. Let me recap what we covered. Number 1. Elective spinal fusion for chronic back pain. High risk of cognitive decline and blood clots in patients over 60, especially when conservative treatments haven't been fully exhausted. Number 2. Elective valve replacement for moderate valve disease in patients over 75, significantly higher stroke, kidney injury, and permanent arrhythmia risk compared to medical management in asymptomatic or mildly symptomatic patients. Number 3. Gallbladder removal for asymptomatic gallstones in patients over 65, unjustified risk when 80% of asymptomatic stones never cause problems. Number 4. Prophylactic mesh hernia repair for small, asymptomatic hernias in patients over 70. Chronic pain risk often exceeds the risk of incarceration, making watchful waiting the smarter choice in many cases. Which of these procedures have you been told you need? Or which one has a doctor recommended for someone you love? Tell me in the comments. I read every single one. There is someone in your life, a spouse, a sibling, a friend, a parent, who needs exactly this information. Someone who's been told they need surgery and hasn't asked the hard questions yet. Send this to them. That one share might be the most important thing you do today. Every week I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. If you want more of that, subscribe. Because your heart, your spine, your whole body, they deserve better than default medicine. One last thing, and this is important. Everything I've shared today is based on published research and my clinical experience as a cardiothoracic surgeon. But your situation is unique. Your history is individual. Before declining any procedure, before changing any treatment plan, please talk to your own physician first. Get a second opinion if needed. Ask the specific questions I gave you. That conversation is not a formality. It is the whole point. Better information, better conversations, better outcomes. That's the chain that matters. Your heart has been working for you every single minute of every single day for 60, 70, 80 years without ever asking for anything in return. Give it this. Take care of your heart.